Early on, we looked for bleeding and fortunately didn't have very much. We're looking for heart function. Is the heart powered up? Are we getting enough blood flow? We look at how the other organs are responding, most importantly, lungs and brain. Larry's conversing now with us. He's passed his test to get off the breathing machine, and so I am hopeful that he'll be able to be in a chair tomorrow, conversing as he had been before surgery. Our patient did not qualify for a human organ nor for a mechanical heart pump. Both of those would be options in most patients who had end-stage heart disease. Because Larry had significant other illnesses associated with his hardening of the arteries, he was deemed by all the regional heart centers, 4 of them in the region of Baltimore, Washington, as a non-flyer. We were very appreciative that he accepted our offer for the experimental transplant in the hopes it would help him, but also because this is a field that's just beginning and so much needs to be learned. I think he was resolved. You know, at some point in your struggle, you become resolved and comfortable with your own demise and with, you know, his decision. He was relaxed in conversation, as was his spouse and the rest of the family. They could joke in some ways about it. I think that lightened his load a little bit in being able to discuss such an important issue. I think he's grateful to be alive. You know, in many ways, he went to sleep and didn't wake up for literally, 18 hours not knowing whether he was alive or dead, So you wake up after an experimental procedure and you see the lights on the ceiling and then your loved ones around you. That's good news.
Final.
I think it's important to know that we're still on the precipice of a potentially really important therapy, but it's yet to prove itself. And so while we go through the process of adding patients, the patients are critically ill, don't qualify for anything but something experimental. So if we can get a modicum of success, I think that'll translate in a less ill patient quite a bit better.
We have learned a lot from our first patient, so we changed a few things. We have changed our immunosuppressive regimen a little bit to make sure that we do not overly suppress this patient. We have changed an antibody which blocks the similar pathway that we have blocked last time, but in this case it blocks the other end of the same pathway. As you know, that the last time there was a concern of a latent virus in the pig, so this time we made sure that this doesn't happen. The company that made this pig made sure that all the testings were done. New testings were utilized to make sure that there is no latent virus in the pig. In our last case, what we have found out that the screening methods for the pigs were inadequate. They were not able to, screen a latent virus. But this time, the Revivicor has developed some serological testing that indicates a prior viral infection in the pig because it detects the antibodies against that virus. This is an experimental procedure, and FDA has been very kind to us in allowing this, and they have only allowed us because we have taken our time over a period of 1.5 years to investigate what went wrong or what we can change it after Mr. Bennett's case.